So maybe I start. Good morning and good afternoon again, Professor Pontone. So I want to ask you something that is more, let's say, a perspective questions. You know, you are like one of the few clinicians that is collaborating with the computational scientists, our side of the medal, and you know that this is not quite standard for clinics. So as a computational scientist, I hope that, I don't know, in 2030, simulation will become quite standard to improve and to enrich, let's say, the output of classical clinical images. What is your point of view? I mean, what are the difficulties? I know that it's very very time consuming to collaborate with us, and what is your point of view of this collaboration?
Yeah. My personal opinion is that the direction of simulation in medicine is really important, because the simulation could be better than reality. And I want just to share with you one practical example to better understand exactly what I mean. When you do an exercise stress test in a patient, you do this kind of stress test to look for ischemia. And when you do this kind of stress test, you need to detect reduction of myocardial blood flow. But a very common situation in clinical practice is, for example, that the patient is not able to do a maximal exercise. He don't reach, for example, the heart rate, expected heart rate that we need to be sure that that test is true in terms of risk identification and so on. When you do a simulation and you have understood the model that there is behind the myocardial blood flow in a stress condition, all these parameters you can simulate. You can decide which is the expected myocardial blood flow changes if you fix, for example, the heart rate that is the desirable heart rate that you want to apply in that specific model. This means that, for example, we can have a simulated exercise more representative of the status of the patient as compared to the true exercise, which is the main problem. That the majority of the literature in the field of simulation model is comparing the model versus the reality. So you compare the performance of your predictive model against, for example, the true exercise stress test. And this is a paradox, because in this way we cannot understand if we have a further additional value of your simulation as compared to the exercise. What we have to do now is the next step. And the next step is to validate the simulation model against the outcome. What I mean, you take an imaging data set of a patient, for example, CT, whatever you want. You apply your model, and you have just to check if your model is more predictive than worse outcome as compared to the true test. Because in this way, we jump at the paradox of validation, in which we compare one technique to another one to be validated, and in this way losing the potentiality that the new technique is more robust than the reference. That is the point. The true reference for us is outcome, cardiac event, and if we move in that direction, probably we can understand if the simulation model can be more effective than reality.
Thank you. I understand. This is very important indeed.
So,
Professor Pontone, hi. I'm Stefano from ETH Zurich. So I really enjoyed your talk, and I mean, I come from a group where we mostly do MRI. I mean, they mostly do MRI and I do the processing. So the perfusion part is actually something we work a lot, and we are trying actually to fit the constants of the one-dimensional like evolution laws for perfusion in the myocardium from MR, because those have, I mean, MR is a kind of decently high resolution in time. So we lack resolution in space, but we have a quite high resolution in time. So what's your view on like these dynamics of the this fitting these dynamic models to the perfusion in terms of being able to classify or to quantify a possible outcome or on the patient.
Yes, as I told in my presentation before, you have pointed the most important aspect, that MR is robust in terms of temporal resolution and less robust in terms of spatial resolution as compared to the cardiac CT, for example. The problem and the point is we need to understand in the perfusion evaluation which is the aspect that is more important, spatial or temporal resolution. At the beginning, the temporal resolution of cardiac CT was really too much far from any kind of needs, and so therefore it was impossible to imagine the application of CT in perfusion, and therefore there was no doubt MR was the reference. But more recently, two aspects were demonstrated in the literature. First, that cardiac CT has improved the temporal resolution. Okay, now we can have, for example, with dual source CT approach up to 65 milliseconds of temporal resolution. It is really not such as cardiac MR, but is really robust. But the second aspect is that some authors, several groups, has validated the accuracy of myocardial blood flow estimation with a very low number of fitting during the plot of the wash-in and wash-out of contrast edge. So, I mean, we don't need to have a very intensive fitting of the data set to create a good plot to derive myocardial blood flow. The extreme of this situation is that, I don't remember the name of the first author, but anyway, they demonstrated that, for example, we can have just one sample data set at the beginning of the curve and at the peak. And this is quite realistic to provide an accurate myocardial blood flow estimation. So the need of high temporal resolution decreased in the meantime, and in the same time, the temporal resolution of CT has improved. So probably now we are, from a historical point of view, in a good balance, in a good compromise for CT, because in this way, thanks to the higher spatial resolution, we can have enough temporal resolution and more robust spatial resolution to detect, for example, ischemia with high sensitivity, higher than cardiac MR. Cardiac MR has an excellent specificity, but not really satisfying sensitivity, especially in the subset of patients with obstructive coronary artery disease.
Thank you. And can you trigger the point of acquisition? So, I mean, if you have a low temporal resolution, you need to be able to capture the peak. Otherwise, if you probe in wrong points, your peak will be wrong, and then everything will be wrong. Can you do that with the CT?
Yes, what we do usually is that the fitting of the acquisition with dynamic CT perfusion is divided in three different groups with different rate of interval between each acquisition. In the first phase of the curve is not the fitting is not so high, but then we have the maximum fitting as possible exactly at the peak, and usually this allows to catch the peak with a good accuracy.
And how long is the sequence or the exam for the patient for this? How long does it take?
The acquisition is about 35 seconds in free breathing. We don't need, of course, breath-hold, because it should be not realistic in clinical practice, because now there are very powerful motion correction algorithm, MOCO correction algorithm, that fix the images, so you can do the acquisition of CT with the free breathing.
Yeah, thank you.
So there are no other questions. I have a curiosity. So if I'm not wrong, you mentioned the spotted classifications among adverse characteristics associated to coronary artery disease. But then, if I'm not wrong, you mentioned also that calcification can help to stabilize the plaque. So my question is, did I understand correctly? And if yes, which is the mechanism by which in one case calcification is helpful and in the other case not?
Yeah, you understood correctly, and now I better explain this apparent paradox. the main risk for plaque rupture is related to the fibrolipidic composition, okay? And the lowest risk is when you have calcification. So these are the two extremes. Spotty calcification is a sort of intermediate phase where you don't have a large calcification that is a marker of stability, but you have just a very focal calcification inside the fibrolipid plaque. In terms of, from mechanical point of view, in terms of plaque axial radial plaque stress, if you have some region in which you have calcium with a border involved by fibrolipid plaque, that is the typical, we call it the shoulder of plaque, that position, and that is the typical area where you have a higher risk of rupture. If the calcification then is extended and you have a large calcification on the plaque, the risk goes down. This is the explanation from mechanical point of view.
Thank you, so I think it's clear. It's all mainly a matter of size of the calcification. Yeah, that's interesting.
Yes, yes, it's an issue of material, like everything in your work. It's an issue of material.
Yeah.
Yeah, maybe I want to come also again to the, let's say, to the usage of simulation in clinics. I think that a virtuous example is the one that you have cited, that is the FFRCT, that is quite used now also in Italy in a lot of hospitals. I'd like to have like just a curiosity, how much is it used? Is it really used in a lot of hospitals, the FFRCT? So what is the procedure? You send the CT to the US operation. How much is it used, just to understand?
Yes, the FFRCT, now we use FFRCT in clinical practice because we have introduced it for research purpose this in 2012. Then we had 3-4 years just in which we have included FFRCT in a research program, and since 2007 we have started with a clinical program. So if you come to our hospital and you do cardiac CT and there is an indication, we can use and write in the report the FFRCT result. Actually, from a commercial point of view, the main issue of the FFRCT is that there is just one company that provides this kind of tool for clinical use. That is a HeartFlow, that is funded by Charles Taylor, that probably you know very well. And this is the main problem. Just for an issue of patent at the moment, despite there are a lot of other alternatives to HeartFlow FFRCT, because there are a lot of in-house solution scanner producers has developed FFR in clinical practice. They call CT FFR just to have a different name, otherwise there are potential legal issues. There are a lot of alternatives, but at the moment there is no chance to use for clinical aims because there is an issue of patent, as I told you. So the clinical use is limited mainly for commercial reason, not for technical reason or for accuracy reason, because the tool is quite robust to spend in real world and in clinical practice.
And when is used? I mean, if you find the obstruction of the
cord. Yes, actually the indication is when you have a stenosis, is mainly stenosis guided. So you do the cardiac CT, and then when you find a stenosis usually over than 30-40%, higher than 30-40%, then this is an indication for the FFRCT.
Okay, but only if you find the stenosis using CT, not in an hemodynamic procedure with catheter.
No,
in that case, no. You just...
The FFRCT was developed for CT data set, so yes. You can use on top of CT. There is another option that is simulated.
Sorry, I was wondering if it's possible that maybe you find the stenosis using invasive procedure and then you do CT and then you send to Taylor to the HeartFlow, or in that case you just operate?
No, usually the approach is that you start first with the non-invasive evaluation. So if you have and suspicion, you start with CT. If CT is negative, you stop. If CT find stenosis over than 40%, then you send the data set to Charles. They measure FFRCT, and in case FFRCT is pathologic, then you go to the cath lab for treatment. This is the usual workflow.
Okay, thank you.
I have another question, which is also related to applications of modeling in diagnosis. So you mentioned that scars are a better predictor than the pure ejection fraction for sudden cardiac death. And I think that this is very good news for mathematicians because so you don't need a mathematician to measure ejection fraction, but you may need a mathematician or better simulations to interpret how a scar can be painful. So my question is, so when you said that scars are a good predictor, so did you refer only to the size of scar or also to their geometry, or I mean, this is also related to the talk by Professor Frontera. So, so were you also referring to what you can see through modeling, or just by size and dimension?
Yeah, of course, my vision is from imaging point of view, okay, and not electrical point of view, but there is a sort of a matching between what happened from morphologic point of view versus electrical point of view. We need to go step by step. The first step is that scar that we name late gadolinium enhancement, LG, that is the technique to image scar, is an independent predictor per se. So if it is present with a binary approach, present, worse prognosis, absent, good prognosis. And this is the first step. Very easy to do. We don't need engineers or any kind of model. We'll look and that is enough. The second step, and this is a bit more challenging, is how much scar there is. And now we need to quantify the scar in grams, and more important in terms of percentage as compared to the overall left ventricle mass. And now we need technology, because you can do manually or with semi or automatic software. And of course, your contributions start to become important in this setting. And this is the second step. So presence, absence, and amount. Then there is the third step, that is the homogeneity of the scar. I can have 20 grams of scar, but in one patient with a very intensive core, so the signal is very homogeneous, and usually this is associated with a low risk of cardiac event, or the patient could have a very heterogeneity of the scar that usually we measure as a standard deviation of the mean intensity signal. And this is important. This is the third step. And again, your contribution is very crucial in this point. The last step, the fourth step, is the geometry, because the 3D distribution of the scar inside the muscle is important. You can have the same amount, the same heterogeneity, but with different 3D distribution in the muscle, probably you have different risk. The problem is that the usual post-processing software there are time consuming, and they are quite limited in terms of reproducibility. So despite from a physiopathological point of view, all these concepts are quite clear, the extensive use of these models in clinical practice are mainly limited by the limited technical solution to measure all these parameters.
Yeah, pretty clear. But are there indicators already available based on the geometry of these areas?
Sorry?
So I was asking if there are already available clinical indicators based on the geometry of the scars.
No, at the moment not. At the moment not, and we have we stopped the history of the evidence at the third step. So not still data about the fourth step that is jumped.
Okay, thank you very much. So, okay, there is a question in the chat. So, Federica, if you like, you can open your microphone, please.
First of all, thank you very much for your very interesting talk. I just have a very small follow-up question while following Francesco. Well, of course, the first follow-up question is, if in some patients, I've heard about the patients having diabetes or other pathologies, it is not possible to perform LG MRI. So sometimes it is seen MRI that is performed, but in this case, how worse, like how it is possible to predict, to have a quantification or qualitative estimation of scars, and how important is the location of the scar itself?
Yeah. The location of scar itself is very important. It starts from the last point, and there is always, in some specific setting, an evidence on that. For example, I'm talking about the setting of dilated cardiomyopathy or myocarditis, where we know very clearly that the presence of scar with the middle wall pattern in the interventricular septum is absolutely associated with a worse prognosis as compared to the location of the scar in the infraposterolateral wall of the left ventricle. Probably the explanation of this is related to the different distribution of the catecholamine receptor on the surface of the left ventricle. That means that there are some regions of the heart that are more susceptible to arrhythmic disorder as compared to the other one. So if they are more sensitive and you put a scar exactly there, the risk increase. So this is what we know in terms of location. The issue, as you mentioned in the first part of the question, is that some people cannot do late gadolinium enhancement acquisition in the follow-up for several reasons, mainly for renal insufficiency, because as you know, we need to use contrast agent for that. And in case the patient has a severe renal insufficiency, you cannot do this. And the question is, we can use the cine images that we can acquire without the use of contrast agent as a surrogate of what happened at the tissue level, what happened in terms of scar. For sure, yes, because there is now a robust experience of the strain, left ventricle strain, left ventricle deformation that usually has a correlation with the scar. But to be honest, this is not a direct correlation, because as you know, one thing is the tissue changes, one thing is the mechanical deformation. And the mechanical deformation, that is the answer to what happened at tissue level, is an individual answer to the tissue changes. And the adaptative mechanism can be very different between subject and subject. And therefore, the correlation is not direct, and we need to be extremely careful to predict what happened in terms of a scar, just assuming by the formation of the left ventricle.
Okay, thank you very much. Very interesting. From the modeling point of view, it's very complex, because then if you want to estimate properties, then
of course,
you take into account interpatient variability. So it's
yes, it's true, of course, Federica. But when you are used to create a model, okay, with several multiple parameters, and of course, as you know, these models work well when we know and when we have included the right parameters for the model. But it could be happen that sometime we don't know that there are some additional variables that influence the model, but we don't know. And these are the missed variables, because the knowledge has not still arrived at this stage to understand that physical parameter can play a role. And if we missed something in the model, of course, then the model could be wrong result, could give wrong result.
It's always a trade-off, because if you then have a model that is too accurate, then you have too many parameters that you need to tune, that you need to calibrate. So you have an ill-posed problem if you don't have enough or not invasive, and that's our objective measurements. But thank you very much for the answer.
Exactly. Thank you, Federica.
So